So we're going to start talking about psychological disorders by starting with mood disorders. And I'm sure I will split this into at least two parts. I'm not sure where I got this list from a particular textbook, but I know I've added to it from various sources of information, and I'm going to leave a second for you to think about the green question, even though maybe it's a little bit obvious in this case. But what do Abraham Lincoln, Leo Tolstoy, Marilyn Monroe, Vincent van Gogh, Ernest Hemingway, Winston Churchill, Virginia Woolf, Janis Joplin, Irving Berlin, Kurt Cobain, Francis Ford Coppola, Carrie Fisher, Ted Turner, William Styron, Sting, Mike Wallace, Larry Flint, Jane Pauley, and Ben Stiller all have in common? And yes, I'm thinking you may have guessed, they have some kind of mood disorder, whether this is a major depression or major depressive disorder, a kind of just dysthymia of low mood, or bipolar disorder. They have some kind of, all of these people have some kind of mood disorder. So I'm going to talk about various mood disorders. We're going to start with major depressive disorder, and we're not really going to distinguish that a great deal from dysthymia as I keep moving forward. But major depressive disorder suggests that we have at least 5 of the symptoms of major depression or major depressive disorder for at least the same 2-week period, and that this is causing some subjective distress. Dysthymia is generally low or depressed mood, just kind of this overall thing where I usually draw up a figure on the board where there's a just this kind of homeostasis, not feeling much of anything. And dysthymia is just kind of just under that. They don't have a lot of highs, but they don't have a lot of real lows either. Abraham Lincoln actually appears to have belonged in this category of being pretty dysthymic. And I'm going to talk about major depressive disorder and major depressive disorder with seasonal pattern, which is sometimes called seasonal affective disorder. So people who really just have a bad time, usually in the winter, especially the late winter, early spring, and especially in those areas where they're not getting enough sunlight, or there's very little sunlight to the day, typically. And then at the very end, I will talk about bipolar disorder for a little while. So people who have major depressive disorder tend to feel sad and helpless, kind of stuck where they are every day for weeks at a time. This is related to a number of outcomes and causes, and these kind of cyclical feelings that are occurring. One is low energy. So when I'm really sad and I just feel low in energy, they also often have feelings of worthlessness, strong feelings of guilt. They might contemplate suicide. We're going to see, and I think I've mentioned a couple times now when we talk about wake-sleep cycles, and maybe one other time, that they have trouble sleeping. If I have trouble sleeping, it's not necessarily a sign of depression, but it looks like everybody who has a major depressive disorder has had some trouble sleeping at different points in their lives. Whether that is that not being able to get to sleep at night or waking up incredibly early in the morning and not being able to get back to sleep. They usually don't concentrate very well. There's a number of things going on there, from the sleeplessness as well as the focusing on that depression. We have talked about the anterior cingulate cortex a couple times, and about obsessive compulsive disorder, and about pain and all of that stuff. But depression is a kind of social pain, and a lot of times they are spending a lot of time ruminating, and that anterior cingulate is very active, and so it leads to a lack of concentration on sometimes the things that we need to concentrate on. A lot of times if you ask them, they say they can hardly imagine being happy again. And overall, it's not so much these feelings, which we do see these really negative feelings, but what also tends to happen that's causing some of the negative mood is just fewer pleasant experiences over time. And I remember, so I think I have mentioned, I'm not sure in this class, I was very depressed as a teenager and as an emerging adult, and was pretty much contemplating suicide quite a bit. I will say I did not think I would ever get to 30 years old, and I'm really proud and happy to be pushing 50. I'm glad I made it through those times, and to some extent, a lot of those really emotional aspects of depression have left me. But I remember this, just one of the things they say is you start to not enjoy the things that you used to enjoy. And because I was a teenager and moving into emerging adulthood, I thought that happens to everybody. And so it was hard for me to figure out where is the line there, because a lot of things are fun when we're kids that we don't enjoy as much as we age. But for depressed people, this is just overall, they have fewer pleasant experiences. And this is sometimes called anhedonia. It's just not enjoying or not experiencing pleasure or happiness. They may move and talk very slowly. Another aspect to this, though, is sometimes they pace restlessly. They may cry a lot, but not necessarily. This is usually not a long-term thing that someone is going through for months and months and years at a time. What they're doing is having episodes where they're experiencing major depression or major depressive disorder symptoms for a number of weeks, and then they'll feel a little bit better. And as I draw that line of just this is homeostasis, they're falling well below that line, and they're getting up to that line, but they're not really going above the line where I'm having these really fun, really pleasant experiences either. So not really. Usually what happens is the very first episode, that there's sort of a trigger for the first episode, and that usually lasts longer than later episodes, and most patients can identify a trigger, a particularly highly stressful event in their lives that triggered that first episode. I'm going to distinguish major depressive disorder from bipolar disorder, and then talk about major depressive disorder for quite a while, and then do a short amount of material on bipolar disorder. But in bipolar disorder, they're really alternating between two poles, as where bipolar disorder, the name, comes from. It used to be called manic depression, as they had the two poles were depression and mania, but the bipolar disorder is a better description and has less kind of stigma attached to it at this point. Even though for all psychological disorders there is some stigma, it is something that we are really trying to help people with so that they can get the help that they need. And here I have one more person on our list. We can add Russell Brand, who has bipolar disorder. Sometimes they suggest that bipolar disorder is related to creativity, as we see a lot of creative people have bipolar disorder. I should say that the other way around. But people who are bipolar tend to also be creative, but we can be creative without it, obviously. But there tends to be a relationship. We have two different kinds of bipolar disorder that have been distinguished now. Bipolar 1 is really what we used to, I think that would be where we put the people who had manic depression. They have the mania that we tend to associate with bipolar disorder. If we've ever heard about it and seen it anywhere, we see that kind of really restless activity. They get very excited. They might be laughing a lot. They have a lot of self-confidence. They might have some really impulsive actions based on their self-confidence and their excitement, that they're feeling this real high, and they do something that is incredibly impulsive and not really well thought through at all, and can be really bad for them. Sometimes involves spending lots of money. They tend to have rambling speech when they are in their manic episodes, and loss of inhibitions. Whereas bipolar 2, I'm not sure how many people know as much about bipolar 2 or how much we realize that there is this distinction, but they talk about the manic part as more of hypomania. So, and sometimes even in bipolar 1, that mania has a bit of agitation or irritability to it. But in people with bipolar 2, they're not really getting the really positive aspects of what we would consider positive aspects of the self-confidence and excitement, and just kind of really the impulsive activity is something they're having fun with. People with hypomania or bipolar 2, they don't have quite as much energy, and it really is when they are having their hypomanic episodes in those times, it's tinged with this agitation, anxiety, kind of irritability that is just part of that. So they're having mood swings between these two poles, between feeling very manic and feeling rather depressed. It is very difficult to diagnose because sometimes they're not showing real mania, and sometimes they're really not showing real depression. If we look at our homeostasis line now, they're going well above it in those manic phases if they're in bipolar 1, and they can come well down and have those depressive episodes, but they might not. So it's really hard to diagnose. But they do have mood swings. They're sometimes diagnosed with attention deficit hyperactivity disorder because they have that impulsivity problem and some hyperactivity and a lot of energy in their manic phases. They have poor impulse control and impairments in verbal memory as well. Whenever I talk about psychological disorders, I almost always at least have a slide on there showing one of my textbooks renditions of the diathesis stress model. This sometimes looks pretty different from this, but this is the easiest one for me to talk from and explain. And usually the way we consider the diathesis stress model to occur, so that we have this genetic predisposition, and that itself is it's not a destiny, right? It's a predisposition. And usually what we see is that genetic predisposition and some kind of childhood trauma. And both of those things together give us the vulnerability to have some kind of mental disorder. And so what then makes this more and more high probability that we're going to have this mental disorder is dealing with excessive stressful circumstances after that point. And in fact, even with the genetic predisposition and the childhood trauma, with minimal stressful circumstances, we have a lower probability of having a mental disorder. I have some just general statistics here. You never need to know the general statistics, but they're interesting, and they are an important thing to keep in mind, especially if you are dealing with any of these problems, that I'm going to say at some point that, I'm going to say it now apparently, that something like, it's estimated that 51% of the people go in to seek kind of psychological or psychiatric help at some point in their lives. And so this isn't all people with one specific disorder, but looking at all people across all disorders and things that can cause enough stress that we go and seek help. 51% of the people seek help at some point in their lives, which means that that's why I usually put the quotes around normal. What we call normal, and people who are not having any of these issues, supposedly, because that 51% includes the people who go seek help. And remember, there's such a stigma on a lot of this that some people will never go seek help, even if they really need it. So that means 49% of the people appear, quote, normal, but the percentage is even less than that. So what we are calling normal is kind of a little bit actually abnormal. And so we see the percentages for a particular disorder are much lower, but when we put all the disorders together, it's actually more abnormal to not have any psychological problems at any point in your life whatsoever. So at any point, what we see for major depressive disorder is about 5 to 6% of the people have major depressive disorder. In Canada, if we look at Canada and the US, we have a 10% lifetime prevalence. So about 10% of the people have major depressive disorder at some point in their lives. If we look at childhood depression and the proportions, it's about the same for boys as for girls. But after the age of 14, we start to see depression as being more and more common in females. In fact, I have one textbook that says apparently the greatest predisposition for depression is simply being a female, which is a pretty sad thing to say, but I think a lot of that, there are other aspects to this, but I think some of that does have to do with the stigma. And so we had Prerna and her friend come in. I can't remember his name now. Prerna's been in one of my classes. I think his name was Sven. Come in and talk about this stigma, particularly for males. So if you remember, they were doing the Daily Dose podcast, the Daily 2, dose in Spanish, and that hopefully helping us realize that this is a stigma that is not helping us, and it's not very rational in a lot of ways. 15.9% of people with major depressive disorder and 29.2% of people with bipolar disorder at some point in their lives attempt suicide. However, if we also, so that seems like the major depressive disorder, that's not a huge percentage, it's actually a pretty large percentage of people who attempt suicide. But if we look at the rate of death by unnatural causes, it is 28.8 times higher than expected for people of the same age in the general population, which means, so we can die by some automobile accident or some other cause that we might try to find a way to make it look like we didn't commit suicide. I often have people read here part of William Styron's book, Darkness Visible, which I read probably in my late 20s as a real great example of a Nobel Prize winning writer. He wrote Sophie's Choice and Confessions of Nat Turner, a Slave. He's an amazing writer who can obviously write from other people's perspectives, but he wrote about his own depression. And he talks about, and people have asked me, please don't read that again. That's disturbing and it might just give people ideas. And I said to them, because I've been there, and I just think that it's not going to give anybody any ideas that they haven't had before. It is depressing, and the part of the reason that I had people read it before, but enough people have said, please don't do that again. I won't have it. I won't. If you want to read it, you should go read. It's a short book, and it's fascinating, and especially if you handle depression at all. This man's amazing. He can't even get up in front of people and accept an award. He's stuck in his hotel room from his anxiety and depression, and yet Darkness Visible communicates very well this experience of depression. But he's going through and talking about the number of ways and the number of things he's thought about as ways to kill himself where nobody would realize that he had done this to himself. So if we look at that, 28.8 times higher than for other people of the same age in the general population, this suggests that maybe more people are committing suicide than are put into that proportion above. Again, it's not usually long term. We usually have episodes as more common, and the first episode is usually the longest, and it's triggered. If we look at the genetics, people who have early onset major depressive disorder, so this is people who get depression before the age of 30, they have a high probability of other relatives with depression, anxiety disorders, ADHD, substance abuse disorders, obsessive compulsive disorder, and irritable bowel syndrome. If we look at late onset, so people who are getting depression after the age of about 45 or 50 years old, they have a high probability of relatives with circulatory problems. So there are genetics involved. There is no simple, I'm going to point to a gene and say this is a predisposition. It's not that simple. And the degree of heritability is a moderate degree of heritability. If we look at the concordance rates for identical twins, it's 2 times higher than for fraternal twins, which suggests heritability. But we know several genes are involved, and no one gene has a large effect. The gene that has been examined the most and appears to have the strongest association with major depressive disorder is called the RORA gene. I can't remember if I mentioned this in the wake-sleep cycles or not, but this is the gene involved with the control of circadian rhythms, which is why we see those sleep disorders as part of depression. And sleep disorders, if I have depression, I have a sleep disorder. That doesn't necessarily mean I have this gene, but that all is very highly correlated as well. Another gene that has been examined, this is another one of those studies by Avshalom Caspi. I know I don't say his first name right, but and this, I think this study is one that has not been replicated, but it's in the book, and I'm going to talk about it anyway, but where we see this real interaction between genetics and environment is the serotonin transporter protein, or the gene controlling that serotonin transporter protein. And we can receive either a short type or a long type from the two alleles from each of our parents. And the short form appears to increase emotional reactivity, whether it's good or bad. And what we see is this, along the x-axis, this measure of the number of stressful life events. And then in A, it is the probability of having a major depressive episode. And in B, we're going to look at the likelihood of some kind of suicide attempt or suicide ideation. And regardless of whether or not we have short serotonin alleles or long serotonin alleles, if we have 1, 2, I'm going to say even 3 stressful life events, that is not so related to whether or not we're going to see depression and suicidal ideation or suicide attempts. But once we get up to maybe 3, but really 4, once we get into 4 stressful life events, then we see this real distinction between whether or not we get 2 long alleles, a short and a long, and if we got 2 of the short alleles, then we are fairly likely to have depression or suicidal ideation and suicide attempts. And I usually make the very not so funny joke that I obviously had 2 short alleles. I did have a grandfather on my mother's side who had PTSD, which we also see related to low levels of serotonin. My mom and I both like to keep moving, and that is going to release some serotonin. And when I get really still, my mom just does not stay still, but when I get really still and I'm laying around, I get very fatigued and tired and kind of depressed. And I usually also, I know I've talked about tryptophan at least once, and since I'm a vegetarian, making sure that I get tryptophan in my diet and not too much of the tyrosine and the things that are going to bully their way past the blood-brain barrier and create dopamine, and not let tryptophan, which is going to help me create serotonin, pass. Even that can lead me to an episode of depression. So it's a good thing to keep in mind. It's not just your genes, it's also environment, but you are much more vulnerable if, in this case, if you have the 2 short serotonin genes for this example, but we also just saw the ROR gene as well. Other biological influences that we see. So one is influences due to hormones. There have been a few studies linking hormones to depression, cortisol and stress. So we actually talked about this a little tiny bit when we talked about sleep-wake cycles for those people who were traveling across time zones, that they were constantly releasing more cortisol, and that led to smaller hippocampi. And again, I think I've said this now a couple times, but I have to say it in the major depressive disorder section, and I will talk about the hippocampus quite a bit. But when we're looking at what's a good treatment for depression, it looks like what helps the most is something that creates neurogenesis in the hippocampus and the neurotrophins, the brain-derived neurotrophic factor in the hippocampus, that allows the hippocampus to basically not shrink and get smaller. And so those flight attendants who were crossing time zones a great deal, they had smaller hippocampi, and that is related to depression, although again in those correlational kind of ways. We also see postpartum depression, where about 20% of women have some kind of postpartum depression after having a baby, and the assumption is some of this at least is due to hormonal fluctuations. I mean, a lot about your body and your life have changed since you were pregnant, but there are these pretty strong hormonal fluctuations in there as well. They've also done a study where they caused a drug-induced drop in estradiol and progesterone, and women who had a history of postpartum, they showed new symptoms of depression. So we do see we appear to have some relationship between our estrogens and our depression symptoms. We also see men with lower testosterone are more likely to be depressed than men with higher testosterone. Another biological influence or biological relationship that we see with depression are abnormalities in hemispheric dominance. And we've actually discussed this briefly before when talking about emotion. So people with more left prefrontal activity appear to be more likely to have more happy moods and increased activity. And in fact, we talked about this as the behavioral activation system before, but we can have people either they can have more left prefrontal activity in general. We actually see this tendency in infants, and that it affects our temperament, and that tends to stay relatively stable throughout our lives. But we also can show people films of or pictures or films, I can't remember which, of happy, pleasant faces, happy, pleasant things happening, and we can raise this left prefrontal activity. And the people who show more of a response to this are people who already had more left prefrontal activity, as opposed to people who have more right prefrontal activity. People with more right prefrontal activity are more likely to be depressed. And we talked about that area before as we actually talked about it as the frontal lobes and the anterior temporal lobes, but depends on which research group and what exactly they're talking about, but it all correlates very nicely, or relates very nicely. So people with more right prefrontal activity tend to be more likely to be depressed, but you might also think of that as the behavioral inhibition system. They're often more easily classically conditioned by negative stimuli. They have a reaction to negative stimuli, and we can show sad or horrible, like burn victims and really horrible pictures to people, and we will raise the right prefrontal activity in relation to the left prefrontal activity. And this is actually more related, so people with depression, this is more related to lower activity in the left prefrontal cortex rather than having more right prefrontal activity. It is relative to the left prefrontal cortex, and it's because of the lower activity in the left prefrontal cortex. And in fact, people who have left frontal damage, so if I have a car wreck or something and I hit my left prefrontal cortex, then I'm very likely to become depressed.